This conference will now be recorded.
Have done so in their organizations. It's essentially a workspace where you can join in on specific conversations. You can share files. You can the way that we were thinking about it is just an opportunity to kind of talk and share best practices, et cetera, for COVID. And it's a pretty simple platform to use. You just download the app on your computer or on your phone, and you can turn on or turn off notifications and join certain channels based on the topic, and each channel would be specific to whatever topic you identified. And anyway, so it's something that we use internally here at NCHPH. It's also something that we use across all of the NCAs to share ideas and to work on different projects. But we thought it would be nice to have some sort of a way for people to communicate. And the one good thing about Slack that's kind of different from email is that it allows people an opportunity to sign in at their own time, you know, so that they're not lost, and emails don't get lost. I mean, things often get lost in the email, but you can easily identify them within the Slack platform. So that's what it is in a nutshell. And if we set one up, we can send you the link to join to make it simple enough and answer any, you know, technical questions if you have it.
Thank you. This is Zara Marcellian from La Maestra. Good morning.
Hey, Zara.
I wanted to ask, what is the name of that platform? I joined in a few minutes late.
It's called Slack, Zara. Have you heard of it? Slack?
Slack, maybe, but I don't know. I think I'll look at the link that you're sending. Of course, my IT guys will know, so that would be cool.
Yeah, and Zara and the rest of the gang, I mean, we kind of wanted to do it because we know everybody's inundated with emails and there's so much communication going on right now, even just around COVID, that it's tough to keep up with. And we thought we would try to find some way to, you know, provide a quick and easy way for people to communicate on topics pertaining to COVID or to public housing, primary care in general. You know, the example I gave to these guys was, you know, when I was a kid, they had the old Batman television show, and you know, in Commissioner Gordon's office, there was a bat phone that went directly from, you know, the bat cave to the commissioner's office. And so whenever they needed to, you know, discuss something or share information, you know, they could do it instantaneously, and they could be, you know, assured that somebody would be, you know, listening. So I guess we can't quite replicate the bat phone, but we thought this might be helpful. So if people are open to it, you know, we'll initiate it. So I guess if anybody thinks it's a bad idea, just you know, speak now. Okay, well, all right. So Saki, it sounds like we're going to give it a try.
Great, and you know, this is something we were thinking about doing anyway, and COVID is just a good example of a way to focus some of those conversations. So I think it would be, I mean, it's definitely an immediate need, but also kind of an ongoingly, it would be beneficial for all of us to communicate through Slack.
Okay, well, thanks, Saki.
I have the kids at home. I'm sorry. I'm sure you can hear them in the background. I know everybody else is kind of in the same boat. The kids are home, so a lot of sounds of life in the background.
Well, I wish I had their energy. All right. Well, at this point, again, thanks for getting together. We wanted to have a chance to talk about COVID and overall how it's impacting the health centers, and you know what the health centers' needs are. We're also in communication with HUD, so if there's something you'd like to get out to the housing agencies, you know, we can try to facilitate that as well. I'm going to turn it over to Dr. Jose Leon, our Chief Medical Officer, who's worked with Saki to put the agenda and so forth together, and then we'll just we'll open it up for discussion as we go along. So, Jose, why don't you go ahead?
Yeah, thank you, Bob. Good afternoon and good morning, everyone. Thank you for joining us. And first and foremost, thank you so much for all the activities and everything that you're doing to address the COVID-19 pandemic. I understand that there are some places that are more affected than others. For instance, I understand that New Jersey, New York, California are the states that have been greatly impacted by the pandemic. So thank you for everything that you're doing to help the underserved populations that you serve every day. So thank you so much. So for today call, we would like to discuss with you any training needs that you may have, any challenges that you are having to address the pandemic, and any best practice, anything that you are doing, so we can collect all that information and share it with the public housing agencies and the other health centers. As you may know, NAC has a page, a COVID-19 page, and on that page there is a section for special populations. So what we would like to do is to share any information that you may provide to the group, so people can implement either any best practices or any policies that you have in place, or any challenges. And at the same time, our idea is to have a conversation with HUD and the public housing agencies, so they can work with the public housing primary care grantees and the health centers in or immediately accessible to public housing to address the pandemic. So one of the things that you may be aware is the CDC has all the recommendations and guidelines to provide services to patients whom either are suspected to have COVID-19 or those confirmed cases. In any case, CDC has some excellent recommendations for outpatient clinics in regards to, for instance, all the ambulatory visits should be delayed and reschedule elective activities and postpone routine dental and eye care visits and delay inpatient and outpatient elective procedures. So these are just basic recommendations for clinics. I understand that each health center has made their own policies and health centers are working with the state health department or the local departments of health, and probably you are getting more recommendations or from these agencies. So CDC as well has other recommendations, and I understand that based on what I'm seeing on NAC's website and the webpage that they have, some health centers are using the face-to-face visits and, or telehealth, and some of them are recommending to have different schedules. And if you have sick visits, for instance, you can see the sick visits either in the morning or afternoon, and the well visits again separate the sick visits from the well visits. And in some places when there is other rooms available, I understand that there have been locations or rooms that have been accommodated for testing and provide and so you can provide care to patients who are suspected to have COVID-19. As Bob mentioned, there is a HUD's website that is dedicated to addressing the COVID-19. Specifically, this is for public housing agencies and public housing residents. So as I said, we would like to hear from all of you, any action that you have taken or implemented to address the issue, and if there is anything that you can share with the group, with the National Center, so we can provide that information to other health centers who are not able to join us today.
And Jose, I'll pass along just a couple of things that feedback that I received from HUD relative to what public housing agencies were particularly interested in. And it seems a lot of them were interested in finding out how their residents could access virtual or telehealth, more easily, particularly for their elderly and disabled residents. And also a number of the housing agencies apparently are interested in becoming test centers, if that's something that you guys can facilitate, or we're not sure if that's really more a local public health department or state department of public health matter. But it was the telework was just a very big issue for them. And again, people are interested in how they can get testing. And they're also interested just in general in how the housing agencies can be helpful to the health centers and what they're trying to do. So go ahead, Jose.
Thank you, Bob. So there are some actions that on HUD's website, specifically some policies in regards to I mean, these are recommendations or policies for public housing agencies, and some policies in regards to eviction and suspension of violations, and anything that is probably related to the smoking cessation right now yeah, I mean, they are trying to stop any suspension or any issue that probably they may they're having with the residents. So again, HUD has excellent recommendations and policies. So I'm going to stop for a moment, and first I would like to hear from the health centers, and probably I'm going to put someone on the spotlight right now. And Zara, you and I have been talking about the response that La Maestra is doing in California, and I'm not sure if you have anything else to share with the team in regards to how La Maestra is addressing the issue in San Diego.
Oh, thank you so much, Jose, and hello to everybody. Well, right away we did start a screening that is utilizing just one entrance for staff, patients, and everybody, and then do the screening and separate out. As Jose was saying, we had areas for isolation, and then we ended up, because of the volume, we ended up using one building as the area designated for people that were presenting with symptoms. And so we're able to separate them out like that. We still have services that are walk-in for well patients, even though we don't encourage it. We've moved a lot to the telephonic visits, telemedicine visits. But there are, like prenatal visits. There's still pediatric visits, vaccines that still need to go on. And so we really wanted to protect them. We're doing home deliveries of pharmaceutical, prescriptions, county-wide practically. We've expanded that. We also have tripled our food pantry. We're seeing a lot of seniors, youth, especially those kids. They can't get the food from school anymore. So their families go there. Also, we have a hot meal program distribution from 11:30 to 12:30 every day. And I think, 250 families came through yesterday. They drive through, and it's a parking lot across the street from one of the main clinics. And the cars pass through, and we can give them two hot meals, breakfast and lunch, all together. And they just, pick it up. And if we have, sometimes, like we just had a big donation of blankets. So we gave blankets out because it's still cold here, for San Diego, that is. And then any other useful, product or so forth that we get donated that could help them. So we've seen in some of our units great responsiveness to telephonic visits. This is like the medication-assisted treatment, behavioral health, counseling. any kind of counseling, behavioral health. It seems like it's been very accepted, and people, it seems like the patients really do like speaking to the provider on the phone. As sometimes they have issues of transportation, and some of them they feel more comfortable because nobody's like looking right at them. Even if it's through the telemedicine, that seems to help reduce that kind of trepidation to talk about yourself and what you maybe are ashamed of or what you're trying to change. So it just seems like a modality that's really taken root in that whole department. We're still providing services via telemedicine, some in these correctional facilities as well. Our seniors are really isolated, and so we're trying to encourage social connectedness of some kind, not just to check up on them, but also to provide them a way to share information and still connect with each other. So we have like these, it's kind of like a bigger case management model, where it's not really case management, but it's like checking up on them. And did you know that you can call for a telephonic visit? A lot of our patients didn't even know that they could be doing that. So, and then it's a way to connect, and do you have enough food, and who goes shopping for you, and just kind of keep them connected. I think that's one of the consequences we're going to see from all this, isolation, is that, people are going to really suffer because they're not able to connect, increasing the anxiety, depression. Domestic violence has gone up. We see that in our human trafficking and domestic violence unit. It's just, we're going to see a lot of unintended consequences. Anyway, thank you for letting me share.
Thank you, Zara. Zara, I just have a follow-up question for you. This morning, I was watching the news, and here in the DC area, one of the issues is with the immigrant population, and I understand that is a big issue in San Diego. Specifically, the mayor here in DC was people, that they need to seek care regardless of the immigration status, because people are afraid of going to a clinic and receive care. So, what is your experience with the immigrant population in San Diego?
Right. I think that's very correct. Unfortunately, the public charge, the expansion of the definition of who would be counted as a public charge, that was very unfortunate when it happened. It was right before all of this COVID hit, and people were really scared, and all of a sudden they thought, okay, we know we can't, food stamps, okay, we can't do that. We know we can't apply for that because we have this application pending with immigration and it's going to be considered a public charge. Well, will medical services be considered a public charge? I mean, it just, the whole perception of any kind of assistance, even if you could qualify for it, they just didn't even want it. They don't want to deal with it. So what they do is they just come in and say, I'm self-paying and, or I can't afford anything and I need help. And we respond accordingly. But yeah, that is a huge problem. And we have our immigration department as part of our circle of care, and they're very well versed on, keeping up with the different regulations. I do know now that I received a notice saying that the public charge, immigration, all of that, it's all kind of relaxed right now because they want to encourage people to go in for care and not show up at the emergency rooms where they don't have capacity.
Yeah,
it's good to know. Hey, Zara, one quick question regarding your communication with the seniors. How are you facilitating the communication with seniors and the social connectedness? What tools or methods are you using?
Well, some are on like FaceTime, something like that.
Mm-hmm.
And FaceTime. Yeah, they do that. And but unfortunately, the technology, some of them aren't as literate as others.
Yeah.
They might not have younger, family members to help them connect. But more on the telephone and checking in. And then when people, let's say, drop off some items like, groceries or something, then, they'll maintain the social distance, but they can still see each other. So that's important. Some of them have, they don't go on walks together, but they'll, like if they live close by, they'll go out and at least like at a certain time, go sit on their front porch, at 6 o'clock at night, let's say. And that way, at least they can wave to each other, say hi, take walks up and down the street, take turns, so have everybody walking together. I don't know. I mean, they're just really coming up with some creative ideas. Our microcredit program, we had the women that, wanted to participate, a lot of them did, got a lot of donated materials and elastic, and they have their sewing machines at home. Those that, are seamstresses and, create products to sell and so forth for their businesses. Well, they started making masks for adults and for children out of this donated material. And it's not going to, prevent somebody from getting infected. However, our provider said that it would increase the life of the N95 a lot longer if you wear the mask that they make over this, over the protective gear. And plus it's a kick because, there's colorful material and, it was a way for them to join in and do their part and also get some money to help support themselves.
Yeah. Great.
So, all of those kinds of ideas start coming out. And by the way, we've had a heck of a time getting the PPE protective gear for our staff on the front line. And the testing results, by the time they come back, I mean, our county has been woefully, like totally inept. So that's not a surprise. The surprise is how long it's taking to get the results back. We have had positive cases. And so my concern, of course, moving forward is being able to get a hold of these these supplies,
Right.
It's just like we have to fight. I was fighting all weekend to, from different sources, like, hey, how come you said you were going to send us our order? You get the order, it's like 10% of what you ordered, and they have, excuses. And meanwhile, you're hearing on TV that there's tons of material out there. Where is it?
Yeah.
Okay, Bob, this is Eva. I'm going to need to hang up soon. I'd just like to make a couple of comments.
Please do. Go ahead, Eva. Yeah.
So we're here in northern New Jersey, which is New York metropolitan area, and I don't mean to be the voice of doom and gloom, but let me just assure everybody winter is coming, and we're already in the midst of it here in our service area. So 10% of my staff have tested positive.
Wow.
And a number of them are starting to come back, which is great. But I think that as health centers, what is best practice? Well, plan on any given day having people suddenly go out and try and have as many people cross-trained to do as much stuff as absolutely possible, because you're going to need to do that. We were very fortunate in that we had a lot of IT infrastructure and had started to do limited telemedicine, mostly around behavioral health, but we pivoted pretty quickly to doing a lot of telemedicine for primary care, and that has worked well. All of our sites are still, except for one where everybody's out sick, all of the other sites are still seeing patients in person. I think I want to say that the idea of testing in a public housing facility is a terrible idea. You don't want sick people coming in there and exposing all the residents. I don't know who thought of that, but that's just terrible. We had to shut down dental, so we have created an upper respiratory clinic in one of our dental buildings where we are seeing people who are sick enough to need to see a doctor. Mostly we're telling the sick folks to stay home and we'll deal with them on telemedicine. But if you're an asthmatic or a diabetic or a hypertensive or whatever complications you've got, if we need to see you, we will do that under very, very restricted conditions. As Zara said, PPE is short. I think the other best practice that I would like to mention is we've been very fortunate. We have a Congresswoman, Mikey Sherrill here, who has been on the phone with us and 3 local hospitals every morning at 9:30, 7 days a week. Yep. She has been on the phone with us, and we are getting updates from each other to talk about current status. And in our service area right now, the ventilators are maxed out. The hospitals are overwhelmed. Things are grim. Yes. And yet we're open. We're trying. Our major goal of the moment is to keep people out of the ERs if they don't absolutely need to be there. And so what we've been able to do with telemedicine and with seeing people in person, we think we're making somewhat of a difference. And I think the other best practice that I would suggest is to talk to the local hospitals about testing. So one of our hospitals now has a machine that can do 2-hour testing. Oh, wow. And they have allocated 10 tests a day for our patients. So we do the swab and then they are able to do the test. But that just happened this morning. Okay. So the idea that, that we collaborate with the other providers in the area to the extent we can. I think the biggest issue for most of the health centers is money. Yes. That we are bleeding money. Yep. And the revenue has dropped through the floor while the calls have increased by 30%. Yep. But people aren't coming in. And the other thing that we achieved here in New Jersey, and I don't know that there are other states that can do this, is we fought very hard to get telemedicine for the uninsured. Mm-hmm. So we will now get charity care reimbursement for telemedicine for uninsured patients. And that is huge for us. It's huge. And that may mean that we can stay in business.
Yeah, so I just have a quick question. Thank you so much for all of those insights. We've looked at the UDS data, and I think around 40% or so of PHPCs are currently providing telemedicine, but in this crisis, everyone is ramping up their telemedicine and telehealth programs. And I'm wondering if you have, other than finding this resource, which is huge, any other advice on how health centers can ramp up their programs, because it seems like they weren't doing it so before, but so I just wanted to make sure that they have the resources or whatever it is that they need in order to expand that type of care.
Well, I think that what we have been told now by CMS and by state Medicaid and by our local health department is kind of all the rules are suspended. Everybody threw the rules out the window. So we are now able to do even just audio and be able to bill for it, right? So you don't need to have it took us like an hour to get the patient set up with Zoom and make sure their mic worked and the video worked and the whole thing. But all the patients pretty much have a phone. And so that I think is a big deal for us. The other thing that the health centers do need to do is figure out workflow. And we had a couple of very smart doctors set up some templates that work in our system so that we understand, what the patient rep does, then what the MA does, then what the doctor does, and how that workflow works. And the other real complication is translation. So almost 70% of our patients require translation. And while we have a lot of providers who speak Spanish, not all. And so how that works, varies for us site to site, the provider to provider, but I think that each health center, in order to get this going, is going to have somebody create the templates for everybody else, and then what is the proper coding. And we've told the providers, don't focus so much on coding. We will do that at the back end with our billing department.
Yeah, that's really good advice. The workflow is definitely different now.
Yeah.
And how cultural liaisons, in our case, who are translators, and they really help the providers and the whole team and the patient. It's like, how do you get them also on that same modality if you're just doing telephonic visits, for example? And how do they tap in, and how do they support, and how much information can they collect from the patient before, just like going through, taking, their medical history, for example, before the provider gets on the phone. Those are all still being developed,
Yeah. So guys, I'm really sorry. I have another meeting that I've got to run to, but thanks so much, and we appreciate everything you're doing on our behalf.
Okay, Eva, take care.
Thank you.
Yeah, thank you. Good luck. Yeah, are the protocols. I mean, there's tons of new protocols that health centers have had to come up with and develop, to address all of these issues.
Yep. Hey, and relative to that, Zara, I talked to Veronica Clark at TCA in Chicago day before yesterday, and she was saying, kind of consistent with what you guys are saying, that basically money, protocols, and supplies were her big issues. And she was wondering, just have you
need help with funding just to keep the doors open? First responders on the ground in the community. That's what works. Our models are great. If we can't be there, good luck to the emergency room.
Yeah.
I mean, and what exactly are they going to do for these patients?
Hey, Zara, going back to the screening stuff. So we talked about, kind of doing screening telephonically and then, telemedicine in general. But and you also have a separate building that are you screening all the patients before they go into your other facility outside or in another building, or?
Yeah, no, outside. We put up these big tents.
Yep.
With heaters underneath, chairs, no chairs, forget it. We don't want people sitting next to each other. But, strategically placed. There's a whole flow there. The whole team is down there doing the screening. And they have that, what is that called? The thermometer that is basically not the one you put in the mouth. It's the forehead.
Oh, yeah. Yep. No, I got you.
Okay.
The infrared.
Yeah. So those are basically, what we're utilizing. And we have a whole procedure for people to go through, get screened, staff included. And that's how we're separating people out.
Okay.
Zara, one last question for you, because this is something that I believe is really important, and Eva mentioned it. Any workforce issue, any issue that you have with your staff?
Well, yeah. I mean, number one, we had to furlough a lot of people. Okay. So dental, for example, we still are keeping 3 dentists for emergency dental. All the private practitioners have closed their doors already for how many weeks?
Yep.
So we have 3 sites for emergency dental. Everybody else we furloughed. What are they going to do? Sit around and do what?
Yeah.
And then that relieves our our payroll. So we had to go like department by department, see exactly who was absolutely necessary, who had to self-deselect because of, maybe they wanted to use their vacation hours, sick leave hours, maybe they were pregnant, maybe they had, some, 2 or 3 underlying conditions. And by the way, our seniors, the seniors on our provider team, we had to right away get them equipped at home to start doing these telephonic visits. First, we thought they were going to do telemedicine, all of them. Well, all of them cannot, even with our IT support. They're just not literate enough. And with the computer. So, unless we have an IT person stationed there all the time, and it's very frustrating. But that's how the telephonic and, FaceTime thing really does work with the senior providers that are home. Their numbers are totally ramped up now every day of how many people and patients they're able to talk to. And by the way, a good tip is when you're giving the number for that provider, let's say the provider's calling the patient, make sure that provider gets another phone, any phone, because that patient's going to have that provider number forever.
Gotcha.
I mean, that's
this is Kent Carroll from Macoupin County, Central Illinois, and we had a lot of people that wanted to voluntarily reduce in force. That helped us, but we did have layoffs too. Yep. Can I ask a question? The lady from New Jersey, she said that they're getting paid for telemedicine for the uninsured. Is that what she said?
Yeah, she said it was charity care. Well, we don't have any charity care in California, I can tell you.
But who's paying the charity? Who's paying the charity care? Their Medicaid program?
Yeah, and Kent,
it sounded like a state program.
Yeah.
Okay. All right. Anyway, what I wanted to let you know is Illinois has done something. It's not started yet, but they are working. They call Medicaid Healthcare and Family Services here in Illinois. They are going to look at historical data very rapidly here because, we're dying on the vine financially. And what they're going to do is look at our historical volume and payments.
Yeah.
Find out what our average payments were a month, and we're going to continue to get monthly payments as if we were operating in whole to keep us viable.
Okay.
On a per member per month basis is what it amounts to.
Kent, how long is that going to go on?
Well, we don't know. I assume, they act like it could potentially happen through the calendar year. But I don't know that for a fact. It's kind of hard to ramp up and ramp back down, but then there'll have to be a reconciliation based on somehow, we got to make that up. But that's to kind of keep us in the ability to keep our staff going. One of the things that we've done at our facility is we've got heated tents outside. Yep. We always were screening first by phone, then temperatures and other questions coming through only one door. And then we have heated tents for anybody that is sick. Only the well are coming through our building. And right. Of course, we only do dental for emergencies. Our problem is that people are so scared now we can't get new patients to come in. But fortunately, telemedicine, literally with a telephone, has been extremely successful. It looks like we're going to have us a whole new culture here of how we provide care, but we're not doing that for new patients. We really do have kind of a philosophy. We do want to see new patients, and that has just gone to nothing.
Yeah. So. That's understandable. And Kent, how are you getting most of your communication, for example, on the Medicaid stuff? Is that coming directly from Medicaid, or is it coming from the PCA, or? No,
our primary health care association is extremely involved. So although notices, public policy, policy notices are coming out from Medicaid, it's almost chronic meetings with the primary health care association, at least twice a week, if not more. And now they've tipped their hat. I think NACHC's going to take over one of those meetings that they were holding, and it's going to be more of a broad national type meeting for us. And I assume the next meeting is going to have something to do. I think we ended up with 1.3 billion for nationwide. But I'm like Eva. We 100 million equated to 57,000 for us. So that lasts about a day, and then we're done.
Wow.
Can I ask a follow-up question to something that Zara was saying, and Kent, I'd like to hear this from you as well, is how have you, I should start by saying that my husband is a pulmonologist and a critical care physician at Kaiser, and so he's right in the thick of this, and he comes home pretty stressed out with the way things are being, the lack of resources and the stress on the workforce. And I was just wondering, what are you guys doing to help support your staff who are, on the front lines that may have gotten furloughed or might be getting furloughed, who are, dealing with all the other stresses in their in the situation? Have you all been addressing those issues? Is it an issue where you are? And I'd just like to hear more about that.
You mean financially and emotionally, both type support? Is that what you're saying? One of the things that we did, this doesn't help a whole lot, and we even did this for our professionals, and this has got us further out on a little limb. We have never allowed sick time for somebody that's been reduced in force, but we decided, my own board of health, I should say we're a health center and a public health department. So one of the things that we've been able to get our hands on, maybe more than just a health center, since I'm in, we're the ones that are responsible for the SNS distribution, et cetera. So I haven't been totally without PPE, and that keeps people at way less of a stress level. Anyway, back to the sick time. We've allowed people to take 2 weeks of sick time if they've been reduced in force, or just if we've reduced their hours, they can take up to 2 weeks worth of paid sick time. That has never been allowed. That's just a suspension of rules on our part. And that has really made people feel a lot better. I started something about 6 months ago. I've been wanting to do it for 10 years. It is a contracted employee assistance program. And they have just absolute daily communications going out, and they have people available 24/7. I think that's helped us too. I'm kind of glad I did it.
We've also had, just to expand onto that, where we have employees that will donate to those other employees that have already maxed out their sick and vacation time. So, some of us are supporting 3-4 people off of that are getting the fun, the paycheck basically through our hours that we've accumulated over many years. So there's all kinds of creative, kinds of new initiatives, new programs that, you just try to keep try to keep the staff that are willing, number one, to keep coming to work, keep them safe, keep their morale high through a lot of interaction. So a lot of support. It's amazing how people on the teams will still, bring something in to share with them that they've made, because people now are worried about getting food from restaurants, with restaurant workers coming positive. Things like that kind of just, and just to know that staff knows that we're so appreciative, and they hear about it on the calls we have together. They see the emails. They see the emails on the weekends. I mean, we're doing Saturdays and Sundays. I'm sure you guys are too. There's calls and meetings on Saturdays, Sundays, doesn't matter the time of day. It's like every day, just to address this issue.
Okay. Hey, can I ask both Zara, and Kent, and have you guys had much interaction with the public housing agency, in your cities?
Oh, no way. I mean, they're not even answering the phone.
Well, I have, but we're a tight little situation here. My public housing, what do they call them? Housing Authority Executive Director is the president of my health center board. So yeah, and then her activities, and her activities director is on our board. So yeah, we've been in pretty good close contact, and that kind of makes things easier for us in that regard. So yes, we have, and we do have communications into their newsletters and daily things that we do. I did want to mention something to you, talking about senior housing or otherwise isolation. Now, this is kind of a unique thing for us too. We're kind of a catch-all here. Seems like nobody wants to do anything, so we do it half the time. You know, we run the public transportation program for the county.
Oh, wow.
We have not suspended our transportation program. We've made some very strict rules. I'm down about 60% of my drivers. Most of them bugged out on me. They say, "Oh my God," you know, because they're retired people or second incomes, or and so they didn't want to take the risk. So we have very strict clean sanitation things, but we don't obviously take very many people at a time. We're doing everything we can to allow people to still get their daily living needs done and to get out of the house. For example, I got a call today about, I guess this is bank day for most seniors or something. Anyway, so they asked if we could still do that, and we are. You know, we space people. We only take one person at a time. Yeah, it isn't probably the most cost effective, but that really seems to be helping people feel better about what we're doing. What we did suspend was hauling people. I'm in central Illinois, and I take people all the way to St. Louis, Missouri, and Springfield, Illinois for the specialties and other things for medical, non-emergency. We've cut that out, but within the county, we're keeping people well and moving, and that seems to have helped.
So any kind of education or outreach activities, with the housing agency, or any kind of work with community health workers or others to either get the message out or to provide some kind of assistance to residents of public housing?
We are
our community. I'm sorry. Our community health worker program for eligibility is super busy, amazingly, and all of our outreach programs, we still are utilizing them to put the message out that telephonic visits are here and all of the other services that we could help them with. I think that is wonderful to have a network like that, because then any information that you need to share can go that way. I'm sorry for interrupting. I don't know who I cut off.
Go ahead, Ken.
We have blasted out the ability for telehealth visits and the connectivity that we want to keep, and probably are going to end up expanding on in the long term. We were heading that way anyway. The people that see the future in this business have said for a while, one out of 3 visits are going to be virtual, or they're not going to happen at all, because the younger generation loves it that way. One thing that we've gone wild with is social media and the radio. We have nonstop. We got this radio station that 35,000 people are listening to at any one time, because there aren't too many radio stations in our area. And we have a weekly show, a daily update, and those things seem to be happening. We put a daily, well, I don't have many daily papers, but we put a update in the paper weekly too. And unfortunately for us, the biggest paper in the county, I don't know how they do this. It's a free thing. You don't pay for it. It just goes to everybody.
Yep.
Bob, that's fantastic, Ken. That's great.
Yeah.
Sorry. We have like 7 more minutes for the call, and probably this question in the middle of this crisis may sound out of touch, but one of the things that all NCAs are working, we are trying to get information about census and whether there is any help that you are providing to your communities to fill the census out, I guess, or to fill out the census. That's some information that probably we're going to discuss today with 20 NCAs, including NACHC. And I just want to get some sense of whether you are working in the middle of this crisis on the census.
Well, this kind of came my way. I didn't go looking for this. Our primary care association ended up getting the contract for Central Illinois, so I'm actually responsible for 2 counties, outreach, education, and update. And we've done everything by social media, phone, and all those other types of things I just mentioned on the daily newspapers that go everywhere and all. And I have 3 college kids that are doing a wonderful job, supervised by my health program coordinator, that they've been on this since February. So we are intimately involved in our primary catchment area, which is the two counties, Macoupin and Montgomery counties, that we have the biggest presence in. So yeah, it seems to be going very well. I didn't get to look at it, but we already had some kind of report come in that tells us how many people have already filled out the census in our area. So yeah, we've unfortunately dove into this one head first.
Okay. And how about you, Zara?
You know, definitely that's something that we added to the outreach workers for them to, you know, to talk about. It's just right now, it's kind of like the last priority. I mean, with everything else, people, you know, people are starving, and thankfully they don't have to worry about getting thrown out. But I mean, there's a lot of other issues going on and fears, and we don't know when it's going to stop. And it's helping provide them that support and that, you know, connectedness, so they feel like they're not alone in their misery and fear right now. So, you know, and then supporting obviously these workers. So census is kind of like at the end of the priority.
Well, on a related issue, HRSA has put out this, I guess, this twice monthly survey to the health centers relative to COVID. And I'm just wondering if everybody's providing that information. And actually, we don't even know exactly what information they've requested in those. We're not sure if it's a survey or exactly what it is.
It's a survey.
I don't know. Go ahead, Ken.
It's a survey. My clinic director fills it out, but I think it's any positives, number tested, and we're still on pretty strict criteria on testing. My governor might open it up here pretty quickly in Illinois, but I think type of outreach we've been doing, those types of things. But I actually haven't even seen the survey.
Interesting. Okay. Yeah.
I know that there are numerous surveys that we're sent from different federal agencies to assess, you know, what's going on. And, you know, I know everybody wants to be at, you know, knowing everything on a real-time basis. and we do too, so that we know how to change up, you know, our flow, operations, whatever. It's just, and then we have reduced staff to do all this. You know, and then we have these companies that somehow kind of try to masquerade themselves as government, you know, pseudo agencies that then, you know, staff sometimes fall for answering these stupid surveys that is just to gather data so they can turn around and pretend like they know what's going on and sell their services. It's outrageous.
Yeah. No, I got you. Hey,
just one more question, Bob. I mean, we are about to. I mean, it's almost 12, and I want to.
Right, but don't end, Jose, because there is one last question I want to ask.
And the only question that I have is, as an NCA, is there anything that we can do for you guys? I mean, any kind of training that you need, resources, or anything that you may need, not only from the National Center for Health and Public Housing, but from any of the other NCAs working on training and technical assistance?
Well, money, money, and money, and supplies, emergency supplies, and sharing protocols, you know, or like, and also, you know, and I don't mean money from you, but if you could look for funding to keep supporting our operation.
Yep.
And kind of, I guess my question is related to really what Jose just asked. And you know, in the folks we've talked to, everybody's kind of overwhelmed with all the different communication channels coming at them. And, you know, Jose mentioned today, for example, we're going to talk to 20 of the national cooperative agreements, which include NAC and Capital Link on the finance side, and ACU and CHC on the workforce side, and high tech and some of the HCCNs and so on. So I'm just wondering, is there a way, is there something that we could all do collectively or individually to get you information in chunks so that it's easier to digest. And I just know that a lot of stuff is being thrown at you guys, both in terms of information coming at you and requests for information that as you just mentioned, that people are seeking. So is there any way we could kind of, I don't know, work together better to interact with you and to communicate better with you?
You know, I think that maybe, you know, by a kind of organizing the information around a topic. Okay, so if it's for, supporting staff or existing staff and protocols or new protocols to share, I mean, just put it that way. Or if it's funding, then like Capital Link, we get tons of stuff from Capital Link, and then they cite they link something else that's going to take you, you know, a dissertation program to read through all of that, okay, digest it, and then like, what can we use today? What is this? So maybe a way to synthesize, what does this mean, okay? Or what have other health centers successfully been able to borrow, okay, or to get through this whole, you know, SBA business or the CARES Act or whatever it is, and, you know, and how do they do it? I mean, that would be the making it as easy as possible. So synthesize the information, and, you know, God, if get a template or something from some other health center that's applied. So at least there's a lot that's similar, save us a lot of time. That would certainly be helpful.
Okay.
Ooh, yeah, that's good, Eva. Help us with the bureaucracy. Make it streamlined. Anything you can do to help us make it a streamlined, efficient, quicker process.
Okay. Did either of you guys participate in the telehealth call last week?
Our staff did. Definitely.
Yeah. Okay.
I didn't. I had staff that did. Yeah.
Okay. I mean, I just thought it was particularly good.
You know, to your question earlier, quickly on the whole, you know, how do clinics ramp up? I think basically they're screwed. If they haven't invested time or found grants or found ways to at least get some, you know, some program going during, you know, the past, I think now it's really going to be difficult without a sizable, you know, bankroll. And because a lot of this comes through lessons learned and, you know, developing something over time to then be ready to launch it during a crisis. What does that mean? That means that they've done their homework. So those clinics that are just starting now, I think better team up with those other health centers that already have it going.
Yeah, that's a good point. Okay. All right. Well, Jose Osaki, anything else? Any last minute words of wisdom or questions or?
No, thank you so much.
Thank you.
All right, and guys, and kind of look out for the I guess the Slack. We're going to try to arrange that. So Saki, they'll get something by email first, or some kind, and maybe a social media, and then we'll set up the Slack, you know, separately.
I'll send them an email with directions and everything on it.
Okay. All right. And I know guys are all busy, so I appreciate you taking the time and have either other issues or other thoughts or things you want to share, please share with us, you know, through email until we get the Slack set up. And once Slack's set up, I think you'll find it pretty easy to deal with. And look forward to talking to you all real soon.
Okay. Thank you.
Thank you so much. You guys take care.
You too.
Bye-bye.
Well.
Okay.
Bye-bye.
Bye-bye.
I know.